Okay, so here we're going to pick up with looking at the ligaments of the knee. So in the previous discussion, we got into a lot of the bones, bony landmarks. Here we're going to look at a lot of the knee ligaments. So first, again, so a lot of these ligaments should sound familiar. Those of you that, particularly that watch sports, when you hear sports injuries, you hear a lot of these ligaments commonly get sprained. So the collateral ligaments, we'll look at those. So we have the LCL, also known as the fibular collateral ligament. And the reason why it's called the fibular collateral ligament is because it has one attachment on the head of the fibula, and then it goes to the lateral femoral condyle. So you see the lateral collateral ligament on the lateral side of the knee, and then on the medial side, you have the medial collateral ligament. Okay, so you see the medial collateral ligament goes from the medial femoral condyle to the anterior medial tibia. So when you look at the ligaments, obviously they're going to resist forces going medial and lateral, okay, or forces in the frontal plane. So, when you hear of the medial collateral ligament injuries, many times the reason why they happen is that someone comes and sort of hits the outside of the knee. So if you look at the laser pointer, someone comes and hits the outside of the knee, and what that causes then is a stress on the medial collateral ligament. And then with the lateral collateral ligament, usually it's a stress coming from the inside of the knee. So you don't see that quite as often. Actually, in my experience, what I've seen more LCL injuries with is actually with wrestlers. When they do takedowns and things of that nature, that's where you typically get a lot of your LCL injuries from. Primarily, though, if I had to say, most of the collateral ligament injuries I've seen, which is common with probably most individuals in sports medicine, is that the medial collateral ligament gets sprained. So those are your collateral ligaments when we're looking at the knee. So next we're going to look at the cruciate ligaments. So again, these are ligaments. Again, most people have heard of these ligaments in some way, shape, or form. The ACL. So if we look at the ACL here, here's your ACL. It goes from the anterior tibia to the posterior femur. The PCL goes from the posterior tibia to the anterior femur. Okay, so they cross right in the middle here. So again, make sure you can orientate yourself. We're looking at the anterior knee here. The knee's in flexion. The femur's flexed on the tibia. You can see that the condyles are very pronounced. Okay. So, and the ACL kind of takes a lateral course. The PCL takes a medial course as it comes up. Okay, now here's a posterior view. Okay, so now the right knee is extended. So the femur is actually extended here. So you can look here, you can see, and you can see some other structures. Again, you can see your condyles, but here you're getting a posterior view of the area. Now you're obviously, it's going to be a little harder to see the ACL, but you can kind of see the ACL coming right here. Okay, the posterior cruciate ligament is more in view. Okay, and here's the posterior cruciate ligament right here. Okay, so you can still see the ACL. It's right here, and then you have the PCL. There it is in the posterior view. Here's a picture kind of looking at it from a model perspective. So, the models that we look at in class. So here you could kind of see all of those ligaments there. Again, you have you have your ACL here coming in this direction. You have the PCL, same as we talked about before, your medial collateral ligament here, and then here's your lateral collateral ligament. Now, other structures we're looking at in and around the knee. So we also have the menisci, or the meniscus in the knee. So we have the lateral meniscus and the medial meniscus, and I'm going to talk a little bit about what they are. So these are fibrocartilage. Okay, they sit on the top of the tibia. So you can see here the lateral meniscus right here. Okay, they receive the femoral condyle. So the lateral meniscus receives the lateral femoral condyle, and the medial meniscus is going to receive the medial femoral condyle, and it's also much larger. Okay, so also they tend to say that the medial meniscus is a little more C-shaped. Okay, the lateral meniscus is a little more O-shaped. Okay, and is going to be much smaller. So when we look at the meniscus, we want to say, what is the purpose of these structures? So the meniscus in the knee does a couple different things. One, it's going to deepen the tibial plateau. So if you just look at the bony contour of the knee and the bony congruency, there's not a lot of bony congruency between the tibial plateau and the femoral condyles. The tibial plateau is not very deep. So what the menisci do are they enhance stability by deepening the tibial plateau. Okay, so you can see here, if you just look at the top of the knee without the meniscus here, okay, on the medial and lateral side, you don't have that deepening to increase the stability at the knee. They also help with cushioning, so they help with shock absorption. We obviously know that, in the lower extremity has to bear a lot of weight, walking, running, jumping. They will increase shock absorption. And they also help to increase proprioception, so joint awareness. So kind of a sense of where your joints are in space. That's what proprioception means. So again, part of proprioception is, again, you kind of know what position your joints are in without looking at them, because essentially you have all these, sensory nerves that kind of give you a basic idea of the position of your joints. Well, the meniscus help to provide more joint awareness, which is going to be very important. And obviously we could have meniscus injuries. There's various mechanisms that could cause tears in the meniscus, so they can tear like anything else. So when the meniscus does tear, when a medial or lateral meniscus does tear, they do tend to produce a lot of instability at the knee. It's also very common for them to cause catching or locking in the knee, because the piece that gets torn tends to create a situation where the soft tissue structure could get pinched inside the joint. The medial meniscus tends to be torn more often than the lateral, so it's a much more common injury to have the medial meniscus torn versus the lateral meniscus. Okay, so what's what? So as we're kind of going through here and looking at what structures, so just to kind of review again, keep yourself active in this process and watching these videos. So again, which structure is that? Okay, that would be your MCL. What structure would that be? Be your LCL, okay? Now again, how would we know that it's the LCL versus the MCL? Well, you have the fibula in the picture, okay? It'd be kind of hard to have the LCL without the fibula, because the fibular head acts as an attachment. So what structures do we have here? Okay, here we're looking at the ACL and the PCL, okay? Now, the two areas cross, so the question would become, well, how do you know which one's which? How do you know which one's the ACL and which one's the PCL? So remember, the ACL does take a more lateral course. So this would be your ACL, this would be your PCL, okay? So the PCL comes from the posterior tibia, kind of comes up medially. So it's not a 3D pic, it's not a picture that you can necessarily tell the depth, but just look at the general direction that they're running in. You can see here that the ACL, remember, takes a more lateral projection off of the tibia. So that's a way you'd be able to tell by looking at that. And then there's your meniscus. So again, if we kind of back up and look, if you were to remove the meniscus away from there, you're going to lose that stability at the knee. So again, they help with stability, they help with shock absorption, and they also help with the proprioception at the knee. Okay, so the knee joints and the motions that take place at the knee. So the reason why we're talking about the knee joints is because not only do we have the tibiofemoral joint at the knee, because in looking at the actual knee joint, but we also have the patellofemoral joint or patellofemoral articulation. So the patella and the femoral groove kind of form their own joint, okay? And it is a gliding joint, which it does primarily do gliding, okay? So the patella glides along the knee as different structures apply force to it, okay? So the patella does move superior, inferior, and medial and lateral based on the pull of the structures. Some of the issues that do end up occurring at the patellofemoral joint end up happening because of muscle imbalances and abnormal stresses being placed at that joint. So for instance, it's very common to have a lot of tight lateral structures pull on the patella, which then produces some abnormal stress as the patella kind of rides up and down as you're going through your knee motions. So again, those are some of the things that could sometimes happen. There's something called patellofemoral pain, which is basically a kind of chronic onset kind of issue where there's abnormal stresses placed on the back of the patella as it glides along the femur for whatever reason. Again, usually those lateral structures being tight being the most common cause of that. Then we have our tibiofemoral articulation. So it's the articulation between the tibia and the femur. So you have the femoral condyles articulate with the tibial plateaus. Again, as you see in the picture here, you can see how the meniscus deepen and enhance that articulation. So if the meniscus weren't there and the condyles just had to sit on top of this, you'd lose some of that stability and some of that deepening, okay? Again, as far as from a movement perspective, primarily flexion and extension. You do have some, again, limited rotation. The caveat with the rotation is that the knee has to be flexed. Okay, so here are your tibiofemoral joint motions. So you have flexion or a decrease in the angle between the femur and the leg, and you have extension or straightening. So again, when we're talking about movements and where muscles are and muscle function, so be thinking about for the lower leg to bend like this and come up, the muscle here would be shortening in order to do that. Okay, so what muscles are right back here? Well, your hamstrings. Okay, for it to then straighten and come down, what would have to shorten in order to do that? Your quadriceps on the anterior surface. So again, think of the location and understand how that sort of dictates the functional movement that's going to take place at the joint. Now, tibiofemoral rotation. So there is going to be some rotation that takes place. External rotation, as you see in the picture, is movement of the leg laterally away from the midline. Internal rotation is rotary of the lower leg medially towards the midline. Again, neither of these will occur unless it is flexed at least about 20 to 30 degrees or more. Okay, so you have to get at least about 20 to 30 degrees of knee flexion, because what that's going to do is once you start to get beyond that, so as you go to extend your knee and you start to get closer and closer to straightening your leg out, what happens is something called the screw home mechanism, and what happens is the knee actually locks out. So when you're fully extended, the knee actually locks into full extension, and then that doesn't permit you to rotate the lower leg. The only way you could kind of make, if you look at this picture, the only way you'll be able to make your foot kind of turn in and out like this is if you basically rotate at your hip. Okay, we kind of talked about that when we did meet last in class. We talked about that a little bit. So you do have to flex the knee to kind of unlock the knee joint to produce that internal and external rotation.